regarding bariatric surgery, post-operative ICU care. First, I'd like to نحاول نفتكر أهلنا في غزة. My agenda to put spotlight regarding prevalence of obesity, pro and cons for ICU care, scenarios for common scenarios for post-operative ICU admission, bariatric surgery, post-operative ICU care regarding general supportive measures, and specific complications in case of bariatric surgery. Obesity is a disease, not only a risk factor, and starting even before conception and pregnancy. Increasing global and local trends, either in males or females, all ages, even in children nowadays. It is the fifth leading healthcare problem and the cause of death or risk factor for death worldwide. Regarding the bariatric surgery and weight reduction surgery, we have at least less than 1% chance of achieving sustained targets for body weight if BMI more than 35 without surgical intervention. And less than 1% people who are qualified or candidate for surgery going for surgery. And good thing that the fatal complications for bariatric surgery is less than 1%. And benefits for weight loss surgery, not only treating disease of obesity, but also treating significant diseases, including diabetes mellitus, hypertension, heart disease, and arthritis or reflux diseases. Also, reducing the risk of death in case of cancer. It is contributed to more than 13 types of cancer. So, what are the indications for metabolic or bariatric surgery? We have recent updates. Previously, they bought the cutoff value for a BMI more than 40 or 35. But what is the latest recommendation? If the BMI more than or equal 35, regardless presence or absence or severity of comorbidities, or BMI 30 to less than 35 with metabolic diseases. And why that? Because the long-term results consistently demonstrate safety and efficacy. So, as my colleagues mentioned, that multidisciplinary team approach for patient management and patient-centered management, we should include pre-operative, intraoperative, and post-operative care. As a surgeon, do you prefer to admit your patient post-operative in general on bariatric surgery to ICU? Some people will say yes, some people will say no. Because ICU is a monitoring place, well-staffed, adequate care, continuous follow-up, on-time management, and good outcome, which has really good evidence from patients admitted directly post-operative to ICU has better outcome comparing to a patient who was admitted as a rescue to the ICU. Indirect admission to the ICU means your patient went to surgery, then to the regular ward, and when complication happened, the patient will be shifted to ICU. This was linked to worse outcome, and it was due to poor triage or high-risk patient, subjective interpretation for the data or criteria for admit the patient, individual clinical judgment or organizational or non-medical causes. And to put in your mind, unplanned admission to the ICU is more than 75% iatrogenic and complicated and preventable. And in hospitals should be used as a patient safety indicator. So if you don't plan your patient for the ICU pre-operative and at run you're rushing to the ICU means where is your pre-operative assessment? And it was clearly that the outcome for patient planned for ICU admission was better regarding the outcome and when followed for up to 4 years. Again, some of my colleagues will say concerning regarding the ICU management, especially in our hospital, and the outcome also, but when considering the guidelines and protocols, we are just taking from the Western countries and implementing it in our countries without putting in our consideration our environment, our resources, So definitely reduced critical care provision in low-income countries was not associated with worse outcome as compared to Western countries. So means if you manage your patient stable enough in the ward, may be better than admitting the patient in low-resourced ICU. Do we really need in every patient either general surgery or bariatric surgery to go straight award to the ICU? Definitely not. If we work in a well-organized hospital with high-quality ward staffing and availability of pivotal services like rapid response team or pain management team, so you need not to admit your patient in the ICU. And from bariatric surgery specifically, no benefit in routine ICU admission after bariatric surgery. Why that? Because it's linked to increased hospital stay and cost also. And now we need to have an objective criteria for selecting the at-risk patient. Who's at-risk patient for bariatric surgery? Male patient, more than 45, BMI more than 50. If you will go for laparotomy, not laparoscopic surgery, a patient with PCI or coronary angioplasty, dyspnea, and bleeding disorder. So the scenarios for ICU admission, in case of bariatric surgery, you might have your patient planned for the ICU immediately post-operative. In case of BMI more than 50, a patient with obstructive sleep apnea or obesity hypoventilation syndrome, or any patient requiring NIV or non-CPAP mask. If your patient is critically need monitoring for respiratory or cardiac issues, or your patient have difficult glycemic control. Unplanned admission to ICU means it was unanticipated to have your patient in ICU, but for something happen intraoperative, then the patient will go directly to the ICU, or you might have your patient admitted to ICU as a rescue after developing any post-operative complications. ICU is like, especially if a well-equipped ICU with a lot of monitors, alarms, screens, time-sensitive decisions like an airplane cockpit. So you need to have a very vigilant eye and alert all the time, and you might have, or you should have actually, a checklist. We have a very famous intensivist, Belgian Dr. Professor Vincent in 2005. He implemented a very nice checklist for the ICU and can also be implemented in the ward also, which is fast hug at least once a day, and nowadays is BID. Give your patient fast hugs, BID. Initially started for medical ICU and currently implemented also from 2017 in surgical ICU. F for feeding, so don't forget to feed or give IV fluids for your patient. If you are considering the bariatric surgery, according to the local protocol, the previous hospital I worked on was any patient post-bariatric surgery, the second day we're taking the patient for gastrografin study, and if it is no leak, we'll start oral feeding. Nowadays, also some controversies regarding this plan, but we should put, especially we are in learning care for pediatric surgery in our hospital, we need to put a clear pathway and protocol. Analgesia, it is the fifth vital sign. Pain is the fifth vital sign. So at any time in ER, in the ward, in OR, post-op, you should have adequate pain control, especially in bariatric surgery. You should avoid non-steroidal, definitely, and long-acting opioid. Sensorium and conscious level assessment, thromboprophylaxis, as mentioned by Dr. Aya before, temperature tubes, head up for any patient. So, and especially in pediatric and obese patient, you should avoid supine positioning and early mobilization as soon as possible with consideration of hemodynamics. Ulcer prophylaxis, also urine output control or glycemic control, spontaneous breathing trial or supplemental oxygen, avoiding hypoglycemia definitely, and cuff technique and incentive spirometry, deep breathing, and a very important role for physiotherapy, especially in post-operative and specifically in bariatric surgery. Bowel movement, we should put an eye regarding the presence of ileus, gastroparesis, distension, or bowel motion. Indwelling catheters, imbalance regarding electrolytes and fluids, drugs, for the drugs and in case of delirium or to notice for drain. This is for any ICU patient with some specific points regarding the bariatric cases. In case of complications, we hope will not happen for any patient, either post-operative in the ward or the ICU. Some specific points we need to draw an attention regarding its presentation. Number one, unstable vital signs, increasing fever more than 38.5, hypotension, tachycardia, tachypnea, hypoxia, or decreased urine output. So if your patient in the ward or in the ICU, you developing unstable vital sign, this is very strong alarm. Or developing abdominal pain or colics more than 4 hours, nausea plus or minus vomiting more than 4 hours, fresh bleeding or melena. All these presentations highlighting something need urgent assessment and intervention. And specifically these pediatric complications, number one, intra-abdominal bleeding, leaks and sepsis, obstruction, pulmonary embolism, vomiting plus or minus abdominal pain, abdominal compartment syndrome. We'll try to go quickly regarding these points and towards some general protocol and headlines regarding the management of pediatric emergencies. Number one, you should put in your mind, either surgeon or intensivist, critical time frame. Diagnosis for these previously mentioned complications or situations should be within 6 hours. And if your decision to go to OR should be within 12 or 24 hours. And critical warning, this a specific category of surgeries, not like other surgeries. You need to call immediately pediatric surgeon early. If not available, you have to call a GS surgeon. And it is not typical surgery, or not typical presentation definitely will be there. NG tube usually is the first thing to do for an abdominal catastrophic, and specifically in bariatric surgery, you should avoid blind insertion of NG tube. Avoid non-steroidal, aspirin, Plavix, anticoagulant or antiplatelet, steroids definitely. Thiamine deficiency, especially if some long time happened post-operative, because thiamine deficiency, specifically if you will give your patient dextrose containing solution, glucose 5% ولا 10% يعني as common ringer glucose ملح, it will have a very serious consequences and end by this what we call Wernicke syndrome or Wernicke encephalopathy. You need to have initial assessment, complete physical assessment, and including vital signs plus temperature, because you always forgetting vital sign, lab and imaging. As you better than me, different types and modalities for weight reduction surgery or bariatric surgery, and definitely the anatomy is totally different. So you need to call the surgeon who did the operation, and better in our hospital, Dr. Muhammad Taya, better to have files for your cases and your patient and easily accessible at any time. So you did the surgery, you just call the center and they will give the feedback regarding what procedure happened. Number one, if you have your patient presented by bleeding, either early post-operative bleeding or somewhat more than 48 hours. Initial assessment and management, you should have wide peripheral access, start fluid bolus, cross-matching and type and screen, stop all anticoagulation, especially bariatric surgery cases, usually cardiac, diabetic, they are usually taking more than one anticoagulant drug. Adequate urine output. Surgery might or likely to be the possibility in case of persistent hypotension or drop in hemoglobin or falling hematocrit despite transfusion, or presence of tachycardia more than 120 for 4 hours. Leaks or sepsis, I think this is a nightmare for any bariatric surgeon. What is the presentation? Commonly unstable vital signs, persistent and progressive tachycardia, heart rate more than 120 for 4 hours is the most sensitive indicator of potential surgical emergency. Emergency treatment, you might go for conservative treatment if it is controllable and your patient is stable. Your patient is clinically stable and also lab. The other or third complication might happen regarding the obstruction, and also not like any similar obstruction in other case, and the emergency management should not be conservative. Pulmonary embolism, as mentioned previously, any patient with bariatric surgery, any and post-op patient, high BMI, at very high risk for pulmonary embolism. And the problem with pulmonary embolism, not only that your patient is at very high risk, but also presentation for all complications more or less similar to pulmonary embolism. Vomiting or plus or minus abdominal pain, also as a very serious post-op or bariatric surgery complaint, should be diagnosed, and there are specific pathways to go through. Abdominal compartment syndrome, due to increased intra-abdominal pressure more than 25 through bladder monitoring, and presence of new onset or progressive course of end organ dysfunction, and treatment usually surgical in surgical cases. I hope I brought some lights regarding these things, and thank you.
شكرا دكتور أشرف.